Thanks for joining. Rachel is here. She's one of our graduates and finishing up this project, which I think is a topic that we've all been interested in. So thank you for coming, and I'm going to turn it over to Rachel.
Can everybody hear me? Can you hear me now? Beautiful. So I'm Rachel. I'm a nurse practitioner with critical care. I joined the group recently in November 2024. I've been a nurse practitioner for about 10 years. This is a subject that's always been common practice. You know, blood product utilization and transfusion strategies is something we see a lot. So hoping you guys enjoy the presentation. I'll come back to this screen when we get done for claiming your CE. So blood product utilization, clinical transfusion strategies for the critically ill patient. I'm going to start off talking about the basic blood products that we use: packed red blood cells, FFP, cryo, and platelets. Packed red blood cells, we all know that blood delivers oxygen to the tissues, and the vast majority of oxygen is delivered bound to hemoglobin. So our indications for transfusion for packed red blood cells is acute hemorrhage with hemodynamic instability, i.e. hemorrhagic shock, acute anemia with inadequate oxygen delivery. Our goals generally with this is transfuse for a hemoglobin less than 7. There have been multiple studies looking at this over the years. Most recently, CHEST put out guidelines, and the recommendations still continue to be a restrictive transfusion threshold with a goal hemoglobin greater than 7 for most ICU patients. The only kind of caveat to that is they've done some studies looking at patients with myocardial ischemia and acute coronary syndrome. The MINT study in 2023 looked at this, and they did look at liberal transfusion goals with a hemoglobin greater than 10, and it might reduce adverse events. However, the findings were not statistically significant, so they still ended up recommending a hemoglobin greater than 8 in those patients. The transfusion of 1 unit of packed red blood cell can be expected to raise the hematocrit about 3% and the hemoglobin about 1 gram per deciliter, assuming there's no ongoing bleeding. So next, we're going to talk about FFP. It's the plasma portion of whole blood that remains after all the cellular elements, red and white blood cells, and platelets have been removed. FFP does contain all coagulation factors and other proteins present in an original unit of blood. Indications for transfusion: active bleeding when there is known or strongly suspected coagulopathy, mass transfusion of PRBC because this leads to dilutional deficiency of coagulation factors, and this can be corrected with the transfusion of plasma and cryo, impaired hemostasis and coagulopathy in liver disease, DIC, prior to invasive and surgical procedures if coagulopathy is present or suspected, or for reversal of excessive warfarin if there is active bleeding or you need to perform an urgent invasive or surgical procedure. Your goal for this is an INR less than 2, PT less than 18, and or PTT less than 35. Generally, the more coagulopathic the patient is going to be, the greater the response to plasma. Patients with severe factor deficiencies are more likely to see a significant decrease in their INR following transfusion. The INR of 1 unit is about 1.3, so you should see a good effect if your patient's very coagulopathic. Cryoprecipitate is collected by thawing FFP, and you collect the white precipitate off the top. It's rich in von Willebrand factor, factor 8, factor 13, and fibrinogen. The chief advantage to cryo over FFP is it allows replacements of those factors using less volume. Indications are very similar to that of FFP, with the exception of severe fibrinogen deficiency being an additional indication. Generally, your goal is if you have a fibrinogen less than 50, transfuse FFP and cryo. For fibrinogen less than 100, transfuse cryo until it is greater than 200. If your fibrinogen is greater than 100, but you have an elevated PT-PTT INR, you would transfuse FFP. Platelets. Hemostasis greatly depends on an adequate number of functional platelets together with an intact clotting system. Indications for transfusion may be therapeutic to stop active bleeding or prophylactic to prevent bleeding. Generally, we transfuse platelets less than 10 to prevent spontaneous hemorrhage, less than 50 in active bleeding or prior to an invasive procedure, and less than 100 in patients with central nervous injuries who have multi-system trauma or undergoing neurosurgery or require an intrathecal catheter for anesthesia. Each apheresis of platelets should increase the platelet count by approximately 30K within 10 minutes of the transfusion. There's lots of complications associated with transfusions, the simplest being infection. Transfusion-transmitted pathogens can be present in the donor blood, although the screening assays we have now greatly reduce that risk. There's something called TRIM, transfusion-mediated immunosuppression. Basically, the blood product suppresses or modulates the recipient's immune system, and this phenomenon could be beneficial or harmful depending on the clinical context. And then we obviously have allergic and immune transfusion reactions. Ones we see a little more common are TRALI, which is transfusion-related acute lung injury, rare but potentially fatal. The patient basically within 2 to 6 hours of receiving the transfusion develops acute hypoxemia, pulmonary infiltrates on the chest x-ray, pink frothy secretions, hypotension, and fever. And then the big one we see a lot is TACO, transfusion-associated circulatory overload, which is basically volume overload from a mass transfusion of blood products. Other complications include hyperkalemia, because potassium can be released from red blood cells during blood bank storage. This is very common in mass transfusion patients and is a higher risk for patients with impaired renal function. And you see this being a higher risk in infants and newborns. Hypothermia, because if we transfuse a lot of cold blood, we're obviously going to drop the patient's temperatures. So we need to warm blood products when possible. And a big one that we learn about is hypocalcemia. Blood is anticoagulated with sodium citrate and citric acid. So this leads to citrate binding of ionized calcium, which can drop the plasma-free calcium concentration. This risk is higher in patients with liver dysfunction. So we generally administer 1 gram of calcium gluconate or 500 milligrams of calcium chloride for every 2 units of packed red blood cells. And we make sure and monitor their ionized calcium frequently. Next, I wanted to talk about PCCs, prothrombin complex concentrates. The most common one we see is Kcentra. Left often is profilnine. Kcentra contains vitamin K dependent clotting factors 2, 7, 9, and 10, as well as protein CNS. It can be used instead of FFP and cryo, and benefits of this, it's more concentrated dose and less volume. However, it is really expensive. The dose is 25 to 50 units per kilo based on the degree of coagulopathy. It can reverse anticoagulation due to vitamin K antagonists such as warfarin, but you need to give it with vitamin K. PCCs may also be used off-label to treat severe bleeding related to our DOACs like Eliquis and Xarelto in settings where the specific reversal agent is not available. They do carry a prothrombotic risk, so should only be administered where the benefit outweighs the risk. Less common seen is profilnine. It does not contain factor 7, so you need to give it with vitamin K and FFP due to the lack of factor 7. Dose is 20 to 50 units per kilo. Then we have our antifibrinolytics. So those include TXA and Amicar. So the indications of these are pretty much the same. There's only a few differences. Postpartum hemorrhage, we see a lot of TXA. You give a gram over 10 minutes within 30 minutes of the birth. You can repeat a gram if bleeding does not stop after 30 minutes or if it resumes within 24 hours. We use TXA in trauma-associated hemorrhage. You give a gram over 10 minutes, followed by a gram over 8 hours. And then we also use it in intracranial hemorrhage after TPA administration in conjunction with cryoprecipitate. Amicar can be used for control of bleeding with severe thrombocytopenia. And they also use it for refractory bleeding associated with ECMO. You load the patient with 4 to 5 grams and it's followed by an infusion. And you can also use it with intracranial hemorrhage after TPA administration as well. Then we got our different reversal agents. So protamine's the one we see a lot. It's a reversal agent for heparin and Levinox. The dose is dependent on the dosage of heparin and Levinox. For IV heparin, for every 1 milligram, you give 1 milligram of protamine for every 100 units of heparin given. Max dose is 50. If the PTT remains elevated, you can repeat the dose, but at half the dose. So like if you've already given 50, you can give another 25. Sub-Q heparin, the dosing is different. It's a higher dose of protamine per 100 units of heparin. For Levinox, it's a milligram of protamine for every milligram of Levinox. The concern with this is you can have severe hypersensitivity reactions and it can cause hypotension, cardiovascular collapse, non-cardiogenic pulmonary edema, and catastrophic pulmonary vasoconstriction. Praxbine, which is a reversal agent for Pradaxa. If significant bleeding continues after the administration of Praxbine, you can consider hemodialysis. And Dexa, which I'm not even sure is still on the market, but it's the reversal for Xarelto and Eliquis. Dose depends on the type of whether you gave Xarelto or Eliquis. And then vitamin K we use a lot. It can reverse anticoagulation due to warfarin. You administer 10 milligrams by IV infusion over 20 to 60 minutes, and the dose given is based on the INR and presence of bleeding. You can give it without waiting for lab results, and you can repeat in 12-hour intervals if the INR is still elevated. So now we're going to talk about the elusive TEG. So the TEG is a dynamic test that evaluates the entire clotting process from clot formation to breakdown. And it's important because it's not static like our normal labs, PT, PTT, INR, and gives you more guided therapy for targeting transfusions. So this is a busy slide, but it basically shows you a normal TEG, and then it talks about all the different portions of the TEG, which we're going to go. So the R time is the time until initial fibrin formation. So it reflects clotting factor activity. The K time is speed to achieve clot strength, so affected by fibrinogen. Alpha angle is the rate of clot buildup, also tied to fibrinogen and platelet function. Then you have maximum amplitude, which is clot strength related to platelets and fibrin. And then you have the LY30, which is the percent clot lysis after 30 minutes, which looks at fibrinolysis. So when you look at normal versus abnormal patterns, a prolonged R time suggests clotting factor deficiency. So if you had a prolonged R time, you would consider FFP or your PCCs. Increased K time or a low alpha angle indicates low fibrinogen, and you would treat that with cryoprecipitate. A low maximum amplitude suggests platelet dysfunction or a low count, so you would give platelets or DDAVP. A high LY30 indicates hyperfibrinolysis, so you would treat with TXA or Amicar. You always interpret this in the context of bleeding, volume status, and different medications. So I thought this was fun because it was like showing different TEG patterns, and I thought it was kind of funny that it was all related to alcoholic beverage containers. So like the brandy sniffer is normal, a red wine glass is a factor deficiency. If it looks like a champagne flute, it's more of a fibrinogen deficiency. It looks like a test tube if you have thrombocytopenia, and it looks like an inverted martini glass with fibrinolysis. So I just thought that was a fun slide. So clinical applications with TEG, trauma and massive hemorrhage. It basically enables goal-directed transfusions to reduce unnecessary blood product use. Liver disease and surgery helps identify specific coagulation deficiencies and optimize transfusion decisions. They typically use it intraoperatively. And then cardiac surgery as well reduces bleeding and transfusion rates by targeting therapy to specific deficits. Pros is real-time feedback, tailored transfusion guidance, and can reduce blood product usage. Cons, it does require specialized equipment and trained personnel. It is not universally available, and the clinical validation of using this is evolving. There's a cool video if you guys want to watch it, but it's really long. So key takeaways is we use a restrictive transfusion strategy in most patients. Our goal hemoglobin is going to be greater than 7. You can consider a more liberal transfusion strategy cautiously in cardiac patients. There was a good study called the HALT study that actually recommended to avoid TXA in GI bleeding. It did not reduce mortality and actually had an increased thrombotic risk. So avoid TXA in your GI bleeders. Always tailor your transfusions to clinical context. The TEG will provide a more holistic coagulation assessment that can direct targeted treatment. It helps avoid overtransfusion and treat specific deficits efficiently. And it's essential for critical care trauma and perioperative medicine. And that's it.